really want to extend my appreciation to the organizers. This is an issue which is of mutual concern, and when the communities that come from sexual and reproductive health meet with communities in HIV/AIDS, that really augurs very well for what we hope to achieve and what the future and the current should be. What I thought we'll do is really look and see if we are able to discuss a little bit and have insights into the dual needs of couples, the dual needs of women to strengthen sexual and reproductive health services and HIV interventions in an effort to accelerate the MDGs, in particular MDGs 3, 4, 5, and 6. I think one very common issue here is whether it's an unintended pregnancy or an unintended infection. There has to be unsafe sex or unprotected sex to get either of those. And the issue is, to what extent can we mobilize services, to what extent can we mobilize interventions to address the dual needs which confront us in that process, with the ultimate vision of helping people to attain the highest possible level of sexual and reproductive health. I think the current momentum is upon us. Sexual and reproductive health challenges, including HIV/AIDS, interventions and care, are really part of a human rights issue. It is a development issue as well as a health issue. And it's very good to see that these issues are drawing the attention at the highest level. We have up to the Secretary General coming in and making some very bold statements which allude to what we need to do in order to protect, in particular, women and those that are pregnant from HIV. We must do more for the teenage girl facing an unwanted pregnancy, for the married woman who has found she is infected with HIV virus, and for the mother who faces complications in childbirth. I quote from the Secretary General. If we look at the global momentum, there are a number of players who are coming in. And here I would like to acknowledge all the partners. It's very good to see the extent to which academic institutions, research institutions, governments, UN agencies, civil society are really coming together, mobilizing around these issues. And what we can actually do is to try and capitalize on the momentum that is being generated. In addition to the colleagues who are looking into this issue, I think there are a number of strategies globally where we can discuss. The UN Secretary General's Global Strategy on Women and Children's Health, the recent Family Planning Summit, the Child Survival Summit. Many of these international discourses are really an issue that rally all of us, where we can all rally around a common theme and see if we can capitalize on developments that are taking place internationally. With colleagues, with partners, with IPPF, UNFPA, UNAIDS, WHO, and others, we came up with a rapid assessment tool a few years back. And within that rapid assessment tool, we decided, or we tried to define the two critical issues, that of linkages and that of integration. And that was really in recognition of the need to bring these services together, to say the service provider often is the same, or the person who has a need often has the dual needs, and we need to recognize the need to address those either through an integration process or through a linkage process. Just if you look in terms of some of the opportunities for joint actions, at country level, I know that within the audience, we have people who are program managers, we have people who are also program managers, we have people who are researchers, we have people who are sexual and reproductive health directors as well as coordinators for HIV prevention and care. And if we look at the global strategy for women and children's health, there are critical components. Just looking at the, I don't know if people can read this. This is visible. critical components which are at the country level in terms of country-led health plans. There is a core within that global strategy for integrated packages of essential services and interventions, providing integrated care, health system strengthening, health workforce capacity, coordinated research and innovation. We also look in terms of what is being called for.
Slideshow. Menu. Yeah. Slideshow. Menu.
So if we look in terms of the role of UN agencies and partners, there are a number of other issues, action areas, or action plans where we can work together. And here it is really that continuum for looking at the evidence, generating the evidence, packaging that evidence into critical interventions, and then putting that into policy formulation as well as programs. And here you can see that each of us, irrespective of where we are, we do have a role. That to me is a critical document. It's essentially a blueprint in terms of the sexual and reproductive health community as well as the HIV community, in that there is a role there which is identified. And for each of those roles, one can actually write a fairly comprehensive protocol, and for that protocol seek funding and say we need resources because we'd like to take forward this component of the critical actions which are called, which are reflected, which we are called upon to undertake within that global strategy, including the generation, synthesis of research-derived evidence, and providing a platform for sharing best practices and evidence on cost-effective interventions and research findings. Just if we look in terms of now that we are reflecting on these issues from both a sexual and reproductive health perspective and HIV prevention and care perspective, in particular within sub-Saharan Africa, we can see the disease burden, the disproportionate disease burden in the region. And this is why it becomes very critical at times that we need to reinforce. We need programs that can reinforce each other. If we look at maternal mortality distribution, or we look at the 49 priority countries within the global strategy, which I alluded to, defined by the UN Secretary General, many of those countries that are contributing to more than 50% of maternal deaths, which are more than the 500 per 100,000, are in sub-Saharan Africa. Just looking in terms of unintended pregnancies, maternal mortality, that's the reflection if we map the maternal mortality or unwanted pregnancies. Unmet need for family planning, and this, I guess, again, you see that within our region, we see yet again a high density of the risk of unmet need for family planning. The HIV global burden. Evidence of failure has been seen when our approach has been isolated, because again, we see this in the same populations, distribution within that population burden. Why do we need to look at these issues jointly? I think this is an issue, a question that has been posed, and a question which the conference is trying to address this morning. There are 8 commonalities across initiatives. The common vision, where we can address the needs for women, for populations, and for children together. Common population, where we can serve that population. Common health services, common providers, common behaviors. Very often the young ladies or the young adolescents who are at risk of unintended pregnancies. If you look at just that population, I recall a study where we looked at just unplanned pregnancies, going to maternity services and see who is presenting with an unintended pregnancy. That population vis-a-vis the one which is saying this pregnancy was planned and wanted tended to have a disproportionately high rate of HIV prevalence. And so you can see the risk in that population at times up to 80% of those with unplanned pregnancy tended to have an HIV infection. Critical dependencies and cost efficiency. The target population thus very often is the same target population. And both promote safe and responsible sexual behavior if we're looking in terms of protection against an unintended pregnancy or an infection. Not only in terms of HIV infection, by the way. We also have the problem which is still with us of STIs, and in fact, the data is reflecting that the rates of STIs is much higher, in particular gonorrhea and chlamydia. Amongst young people, that's beginning to go up again. Thus, the need for dual protection, the multi-purpose prevention technologies. We also have the issue of preventing mother-to-child transmission. Traditionally, some of the services for preventing mother-to-child transmission of HIV tended to be stand-alone services. And yet, within those services, there are needs for family planning. I'll come back to this in terms of the rates of unplanned pregnancies when people look at just PMTCT services. It also helps in terms of infrastructure, in that you can build upon a program. I think very often, if you have an infrastructure already and people are using maternity services or are using family planning services, and if you are able to build upon those services to say, we are going to cater for the needs of those that are sexually active. The fact that that lady is coming to a family planning clinic and saying, I would like a method for family planning, it means she is looking for something to be protected from an unintended pregnancy. At the same time, she may not be open, she may not tell you, but she will also be in need of protection from an unintended infection. And we can tailor those services for people who are living with HIV/AIDS. People who are living with HIV, they have a need, and it's a pity that in earlier programs failed to see and recognize that needs, that they have the right to have a healthy sexual life. They have a right to lead a fairly healthy sexual and reproductive life, and it is within their right to demand family planning to be afforded the opportunities for contraception. If we look at the strategies which are available, there are times when we talked of ABC, and I looked and I heard at that time the arguments that went into ABC where it was being politicized. People talked about A, abstinence, some talked about B, and some talked about being faithful, and some talked about compromisation in isolation. But I think for people who are sexually active, the needs are always evolving, and depending on the context and situation, either of them are important. So it is good to promote these as part of a combined package for prevention. If we look at treatment, we started with monotherapy. People were, zolpidem was available at that time, and unfortunately the results were dismal. It was only when we had a combination of therapy where we can address the various aspects of the virus in terms of an antiviral side or something that attacks the enzymatic processes that the enzyme, that the virus uses. It was only when that combination was consolidated within a drug that we started to see results. If we look in terms of the discussion that has gone place for vaccination. Individual vaccinations at that time or initially have become quite a challenge. They are still a challenge, but the only promising one has been where you have a combination, where you can prime the immune system and you are able to boost the immune response. The same applies in terms of service provision, where we can have a combination of interventions available at the same place, where we can offer the services and we can say within the programs or within the services, this is what we are able to offer. Just looking at the family planning, it's very good that there is current discussion on family planning, including the discussions that took place at the London Family Planning Summit. And it's also very good to look at this in terms of that continuum which addresses sexual and reproductive health needs of population, to take into account the high unmet need for family planning, to look into what investments can we put into advocacy and adoption of methods. If we're talking of unmet need, what it simply means is that very often we have a number of people who are sexually active, and yet they don't want to get pregnant, and yet they are not on a method for family planning. And this is where our response can be combined. We can address that issue within family planning programs. If we also look into HIV itself, just to the HIV community, there is quite a momentum when it comes to elimination of mother-to-child transmission. There are opportunities for pre-exposure prophylaxis and treatment for prevention. Much of the discussion is going into that treatment for prevention. We also had hope raised when efficacy of microbicide showed a little glimmer of hope with tenofovir, and we're hoping that additional studies can provide and come up with a much more viable microbicide. The momentum on multi-purpose prevention technologies, where you can have, for instance, a vaginal ring which has family planning or contraceptive element together with a microbicide. We have looked and we have done a number of interventions within WHO, within the program, and one of those with UNFPA, their colleagues from UNFPA. We had a strategic partnership program. And within that program, we have tried to say, how can we work together to firstly introduce evidence-based interventions and then work towards scaling up those evidence-based interventions. And our colleagues within HIV have also been looking into targeted interventions. There are a number of dimensions of targeted interventions. They have looked into this, they have done their mapping, and these interventions do intersect with the cause and the needs we have for HIV prevention. One of the successes in terms of research where sexual and reproductive health and HIV has been working together has been this recognition of the HAT or the combined RRV that can be used to prevent mother-to-child transmission during breastfeeding. This has the benefit of the mother being on a method which she can also use. I think the potential for elimination of mother-to-child transmission, those of you who were at the HIV/AIDS conference in Washington, we heard that for the last 4 years they had not witnessed a baby being born with HIV in DC itself. And that statistics is testimony to the fact that it's possible to eliminate mother-to-child transmission. And we're very pleased with some of these studies. Some of these studies were coordinated within WHO HRRP, the program in which I work, the Kishobora study, done studying here in Kenya and other places. We also have evidence which is looking into what are the outcomes if we integrate all these services or there are linkages. What is it we can use to define and say we have been successful? What has been the implication in terms of uptake of services? What has been the implication in terms of access of services? What has been the implication in terms of quality? Do we compromise quality? Issues of stigma. And it's very good that we can always incorporate some of those research questions as we look into that. This is the rapid assessment tool I alluded to too, and hopefully it is available outside. But it's very good to see that there are a number of countries which have taken up this rapid assessment tool. They have integrated it and they are using it to monitor various outcomes that are related to integration as well as linkages. Just looking at the data in terms of unintended pregnancy, unmet need for family planning amongst women who are living with HIV. Sadly, the statistics is not very good. We are seeing a fairly high unintended pregnancy rates amongst the women who present even in their second pregnancy within PMTCT services. And this is a reflection where I think we have failed those women. We have not discussed with them the totality of their sexual and reproductive health needs. At times, as providers, we make an assumption that, well, she is positive, she may not need family planning, she may not be sexually active. But if we look at the statistics, there's a high proportion of unmet need for family planning within that community, and certainly we need to address that. Our programs need to move into that. We have the tools, just looking at family planning, and it's very good that these tools are constantly being updated. And here I would like to highlight some of the tools we can use to counsel for family planning amongst the communities of people who are living with HIV, including the family planning wheel, which can define or what method can be used based on either clinical characteristics or physical characteristics of the woman. And we are very pleased that this family planning wheel has become one of the highest demanded documents within WHO, which shows that it is finding its way into service provision. It's been translated now into more than 24 languages. And there are electronic versions, including computer-based versions, and now we are working on mobile applications where people can simply look within their mobile and say which method of family planning would be ideal vis-a-vis these characteristics. There is also the strategic approach where at times it is good to make an overall assessment. What is the situation? Do the situation analysis. Use the situation analysis to generate the evidence and incorporate the evidence into the interventions you have and see the extent to which you are making a difference. So by integrating a situation where there is the baseline mapping, then there is the integration of critical interventions and subsequent assessment of outcomes based on those interventions, we can hopefully see the outcomes we are able to achieve within sexual and reproductive health, as well as HIV prevention and care programs. This is well articulated within this short guideline, beginning with the end in mind, so that as we start, we can more or less have a projection in terms of where we are going. We have seen, for instance, in Zambia, during the times they applied to the Global Fund, that they incorporated some of their sexual and reproductive health issues. It took a bit of time, but we're pleased that there was increased recognition or over time recognition that even within Global Fund applications, you could integrate and request family planning commodities. And this is what happened in Zambia when they applied. You get to a situation where you can't say, I simply want condoms for HIV, and yet the family planning clinics do not have condoms. And this has happened. Family planning clinics are clamoring for condoms, and the HIV program is ordering condoms only for HIV prevention. We have also seen some good trends in terms of HIV prevalence, just looking at data shared with me by colleagues from FHR, where there is a decline, for instance, in Kenya, in HIV prevalence and an increase in contraceptive use prevalence. Some of those trends are very encouraging. What are some of these linkages? At the primary care level, we can integrate a number of interventions, whether it's family planning, antenatal care, STI, cervical cancer screening, PMTCT, BCC, all those can be integrated, and we can have a number of indicators we can use to assess. And here, let me emphasize one thing. Yes, there are indicators which are required for things like MDGs. There are indicators which are required for global monitoring. But I think we need each time conceptually to integrate and have our own indicators. Indicators which can be used, which we can base the performance of our program on, where we can see the extent to which we are achieving higher access, for instance, uptake of services. And so we can integrate, just looking at the primary care level, I can think of 1, 2, 3, 4, 5, 6 indicators which can be integrated at that level. And those indicators look at both sexual and reproductive health related outcomes as well as HIV related outcomes. The other is within HIV services itself, whether it's VCT, PITCT, ARTs, programming services or behavior change. There we can integrate and incorporate a number of SRH-related issues. And for that, we can also monitor here, I can think of 1, 2, 3, 4, 5 key indicators. And these indicators also do have outcomes within sexual and reproductive health as well as within HIV services. Reduction in unmet need, proportion of HIV service sites offering or referring for STI treatment, proportion of HIV positive people offered treatment and cancelled on sexual and reproductive health. And within family planning, there are critical proposed linkages that can also be built in. And for those, I would like to add here the issues of adolescent-friendly services or infertility within family planning services, male involvement within family planning services, BCC, condoms, VCT, and others. And within that framework, critical indicators which we can use to monitor the performance, the proportion of family planning service sites offering counseling and HIV testing care, as well as a referral if it cannot be done within that system. So there are a number of these critical indicators we can build in. Some of these we would have very useful numerators and denominators which can be applied in various other settings for scaling up. So, Mr. Chair, thank you very much for this opportunity, and would like to end with this quotation from Margaret Chan that all our debates and discussions have meaning only when they improve the people, the health of people, and relieve their suffering, which I think you alluded to in your